Peter Allcroft. I'm a palliative care doctor down at Flinders Medical Centre and I work in Southern Adelaide Palliative Services.
Hello, I'm Kathryn Hourigan, a consumer advocate. Together, Peter and I co-lead the Statewide Palliative Care Clinical Network of the CEIH. There are many myths surrounding palliative care. We're actually going to explore 5 of those myths. The first myth is raising the topic of palliative care robs people of hope.
As someone's illness progresses, their priorities do change, and whilst the hope for a cure may no longer be there, patients and their families have many hopes. Hope for togetherness, hope for peace, hope for pain control, hope to be able to die in a place of their choosing. And part of what palliative care is doing is helping someone live as well as they can in that moment and still being able to experience wonder, to see a sunrise, to listen to a favourite piece of music, to experience a family get together around the kitchen table. So we don't rob people of their hope, we actually try to instill it.
Thank you, Peter. Another myth is that I am concerned if I use morphine that I will become addicted.
Certainly the medications we use are strong medications. Having information is power and knowledge. When we're using our medications such as morphine in titrated or adjusted doses supervised by a specialist nurse or palliative care doctor, addiction is not a concern that we have. Certainly the body does develop a tolerance to the medication, and as part of that tolerance, it's important never to stop your medications abruptly because significant side effects might occur. But that is not an addiction. So an addiction to morphine is not a concern that we have in palliative care when we're using our medications appropriately and safely.
Thank you, Peter. Another myth is morphine is given to speed up the dying process.
There is no doubt that if we used morphine or someone uses morphine or other strong pain medicines inappropriately and not supervised, they are dangerous. But in titrated amounts, in supervised settings, be it the hospice or at home, good pain control actually lengthens life. Someone who has poorly controlled pain, their life is actually shortened. It continues to amaze me how many people we admit to the hospice from home who have severe pain, and the presence and the skill that our nurses bring to the bedside in circling, making that patient safe, helps with pain management. Using the morphine or other medications appropriately, adding in our social work, our music therapy, or our art therapy or massage therapy, they're all aspects that we use to help bring good symptom control and pain relief. So our morphine does not speed up the dying process. Our presence, our multidisciplinary team actually improves quality of life.
Thank you, Peter. Another myth is that palliative care is only for cancer patients.
100 years ago, infant mortality was very high. Adults died as a result of infection or trauma. And today, we're seeing an ageing population with a rapid increase in chronic disease, such as advanced heart disease, severe lung disease, or neurological problems such as motor neuron disease. The modern palliative care movement certainly looks after a lot of patients with a cancer diagnosis. But currently in my service, probably at least 25% of our patients have advanced heart disease, advanced lung disease, or motor neuron disease. And with an ageing population, increase in chronic disease, this will only continue to increase. There is no doubt that a timely referral to a palliative care service for a patient who has heart disease or lung disease, we can make a significant difference if there are unmet needs for that patient and their family.
Another myth is that palliative care is only for adults.
The majority of palliative care services are around adult care. Fortunately, most of our children in the developed world will live to enjoy adolescence and adulthood. But for those infants, children, adolescents who do have a life-limiting illness such as an inherited metabolic illness or an advanced lung disease or indeed a cancer, the specialist paediatric palliative care services are critical to help meet their needs. They tend to be state-based services and look after metropolitan and rural regions, and each state tends to have their own service, which does link in with the other adult palliative care services, particularly with that change in age from late adolescence into young adulthood. But the paediatric palliative care services are critical to support the patient, the family, support the general practitioner, but also to support the clinical teams that may be looking after the patient as well.
Thank you, Peter, for helping bust 5 common myths in relation to palliative care. Where could people go to for help?
I think it's important when you're seeking information to use trusted sites, and your local general practitioner is so critical and pivotal to good community healthcare. But equally, if you are searching online, to use a reputable site, particularly a site such as Palliative Care Australia, where there will be good information about resources and information for palliative care, and the state-based palliative care associations and state-based health networks.
Thank you, Peter, for talking about palliative care and raising our understanding and awareness of the dying process. I look forward to continuing to work with you in the Statewide Palliative Care Clinical Network.